My English name is Willie and my Chinese name is Shao-wei, and my student numbers is S0741007, and I'm freshman in the NCUE and I'm in the Department of English. How doctors can help low-income patients and still make a profit. Spoken by P.J. Parmer. Colfax Avenue, here in Denver, Colorado, was once called the longest, weakest street in America. My office is there in the same place. It's a medical desert. There are government clinics and hospitals nearby, but there are not enough to handle the poor who live in the area. By poor, I mean those who are on Medicaid, not just for the homeless. 20% of this country is on Medicaid. If your neighbors have a family of 4 and make less than $33,000 a year, then they may get Medicaid. But they can't find a doctor to see them. A study by Mary Hawkins found that only 20% of the family doctors in Denver take many Medicaid patients. And of those 20%, some have caps, like 5 Medicaid patients a month. Others make Medicaid patients wait a month to be seen, but will see you today. If you have blue cards, this form of class discrimination is legal and is not just a problem in Denver. Almost half the family doctors in the country refuse to see Medicaid patients. Why? Well, because Medicaid pays less than private insurance and because Medicaid patients are seen as more challenging. Some people are late for appointments. Some don't speak English and some have trouble following instructions. I thought about this while in medical schools. If I could design a practice that caters to low-income folks instead of avoiding them, then I would have a guaranteed customers and very little competitions. Laughter. So after residency, I opened a shop doing undeserved medicines, not as a nonprofit, but as a private practice. A small business seeing only resettled refugees. That was 6 years ago, and since then, we've served 50,000 refugees medical visits. Applause. 90% of our patients have Medicaid, and most of the rest we see for free. Most doctors say you can't make money on Medicaid, but we're doing it just fine. How? Well, if this were real capitalism, then I wouldn't tell you, but you'd become my competition. Laughters. But I call this bleeding heart capitalism. Laughter. And we need more people doing this, not less. So here's how. We break down the walls of our medical maze by taking the challenges of Medicaid patients, turning them into opportunities and practicing the difference. The nuts and bolts may seem simple, but they add up. For example, we have no appointments. We're walk-in only. Of course, that's how it works at the emergency room and urgent cares and at tackle bills. Laughters. But not usually at family doctor's office. Why do we do it? Because nurses can call for an appointment. She has her phones, but she doesn't have phone minutes. She can't speak English and she can't navigate a phone tree. And she can't show up on time for an appointment because she doesn't have a car. She takes the bus and she takes care of 3 kids plus his disabled father. So we have no appointments. She shows up when she wants, but she usually waits less than 15 minutes to be seen. She then spends as much time with us as she needs. Sometimes that's 40 minutes, usually it's less than 5. She loved this flexibility. It's how she saw doctors in Somalia, and I love it because I don't pay staff to do scheduling, and we have a zero no-show rate and a zero late show rate. Laughters, applause. It makes business sense. Another difference is our office layout. Our exam rooms open right to the waiting rooms. Our medical providers' rooms their own patients, and our providers stay in the one rooms instead of alternating between rooms. Cutting steps cuts cost and increases customer satisfaction. We also hand out free medicines right from our exam rooms, over the counter ones and some prescriptions ones too. If nurse's baby is sick, we put a bottle of children's Tylenol or amoxicillin right in her hand. She can take that baby straight back home instead of stopping at the pharmacy. I don't know about you, but I get sick just looking at those choices. Nurses doesn't stand a chance in there. We also take patients. We are open evening and weekend. We do home visit with jump dead car batteries. Laughters. With customer satisfaction so high, we've never had to advertise yet. Are growing at 25% a year, and we've become real good at working with Medicaid since it's pretty much that only one insurance company will deal with. Other doctors' offices chase 10 insurance companies just to make ends meet. That's just draining. A single payer system is like a monogamy. It just works better. Laughter, applause. Of course, Medicaid is funded by taxpayers like you, so you might be wondering, how much does this cost the system? Well, we're cheaper than the alternatives. Some of our patients might go to the emergency room, which can cost thousands just for a simple cold. Some may stay home and let the problems get worse. But most will try to make the appointment at a clinic that's part of the system called the Federally Qualified Health Centers. This is a nationwide network of safety net clinics that receive twice as much government funding per visit than private doctors like me. Not only that means they have a monopoly on a special funding for the poor, and like many monopolies, there is a tendency for costs to go up and quality to go down. I'm not a government entity. I'm not a nonprofit. I'm a private practice. I have a capitalist drive to innovate. I have to be fast and friendly. I have to be cost effective and culturally sensitive. I have to be tall, dark, and handsome. Laughters, applause. And if I'm not, I'm going out of business. I can innovate faster than nonprofit because I don't need a meeting to move a stapler. Applause. Really, none of our innovations are new or unique. We just put them together into a unique way to help low-income folks while making money. And then, instead of taking that money home, I put it back into the refugee community as a business expense. This is Mango House, my version of the medical home. In it, we have programs to feed and clothe the poor and after-school programs, English classes, churches, dentists, legal help, mental health, and the scout groups. These programs are run by the tenants organizations and amazing staff, but all receive some amount of funding from fees profits from my clinic. Some call it social entrepreneurship. I call it social service arbitrage, exploiting inefficiencies in our healthcare systems to serve the poor. We're serving 50,000 refugees a year and less cost than where else that would be going. Of course, there are downsides to doing this as a private business rather than as a nonprofit of a government entity, less taxes and legal exposures, less change in Medicaid rates and specialists who don't take Medicaid, and less bomb threats. Notice there's no apostrophe. It's like we're going to blow up all your refugees. Laughters. We're going to blow up all your refugees, but then we went to your English class instead. Laughters. Applause. Now you might be thinking, this guy is a big difference. Laughters. Applause. Uncommon. Laughters. A communal narcissist. Laughters. A unicorn, maybe, because if this was so easy, then other doctors would be doing it. Well, based on the Medicaid rates, you can do this in most of the countries. You can be your own boss, help the poor, and make good money doing it. Medical force you write on your school application essay that you want to help those less fortunate, but then you had the idealism beaten out in training. Your creativity bred out of you. It doesn't have to be that way. And you can choose undesert medicines as a lifestyle specialties. Or you can be a specialist who cuts costs in order to see low-income folks. And for the rest of you, we don't work in healthcare. What did you write on your applications? Most of us wanted to save the world to make a difference. Maybe you've been successful in a career but are now looking for that meaning. How can you get there? I don't just mean giving a few dollars or a few hours. I mean, how can you use your expertise to innovate new ways of serving others? It may be easier than you think. The only way we're going to bridge the undeserved medicine gap is by seeing it as a business opportunity. The only way we're going to bridge the inequality gap is by recognizing our privilege and using them to help others. Applause.